Good evening, one and all. First of all, I would like to congratulate AIIMS RISHIKESH unit and KAPLAN Medical for organizing this webinar on tracheoesophageal fistula. I'm grateful to Professor Satyashree ma'am, who has invited me to give the talk on the anatomical basis of tracheoesophageal fistula. So before I start my talk, I would like to read a quote by a very famous author, Keith L. Moore, who is no more with us, but he said that you will remember some of what you hear, much of what you read, more of what you see, and almost all of what you experience and understand fully. So, to understand any anomaly and its correction, it is essential to know the anatomical basis of the same by learning its development, who has written a book on embryology. The title of the book is known as Before We Born. So when we hear this word, this tracheoesophageal fistula, the very first question which comes to our mind is, what do you mean by tracheoesophageal fistula? So an abnormal communication between the trachea and esophagus due to incomplete separation of the trachea and esophagus during the 4th week of development. It is called as the tracheoesophageal fistula. It is commonly associated with esophageal atresia. Now, the newborn infants with these malformations have cough and choke during, eating due to the aspiration of food and saliva into the lungs. Now, this tracheoesophageal fistula represents one of the most, common congenital anomalies seen in the major pediatric surgical centers. And out of 3,500 births, one case you will be getting of the tracheoesophageal fistula. So the infants with tracheoesophageal fistula classically present with, the respiratory distress, then they'll have the feeding difficulties, choking, and there will be the risk of aspiration. Now, this tracheoesophageal fistula is most commonly associated with some or other congenital anomaly. Particularly, you can say it is associated with the cardiac defects. Similarly, this esophageal atresia, which is a related congenital malformation with a similar presentation of the tracheoesophageal fistula, and it can occur with or without the presence of a fistula. Now, associated with the vectoral complex, I mean, V stands for the anomalies of the vertebra, whereas A stands for the anal or the gastrointestinal tract atresia. Now, the C stands for the, the congenital cardiac defects, whereas TE stands for the tracheoesophageal defects. Then RA stands for the renal and the distal urinary tract anomalies, whereas the L stands for the limb lesions. So in order to understand the anomaly, let us see how the trachea and esophagus develops. Now, when we see this diagram over here, in this diagram, you can appreciate the anatomically airway, it is divided into upper respiratory tract and the lower respiratory tract. The upper respiratory tract, which you can see in this diagram over here, it consists of the nostrils, the nasal cavities, and then we have the paranasal air sinuses. Similarly, when we talk about this lower respiratory tract, it consists of the trachea, which you can appreciate in the blue color, right? Then we have the principal bronchi, you can appreciate. We have the terminal bronchioles, respiratory bronchioles, and alveoli. Trachea, it is otherwise called as a windpipe, which is made up of cartilage and the muscle, and it is lined by the mucous membrane. Whereas the esophagus, which is just posterior to the trachea, is a muscular tube. Now, when we recall this formation of foldings, we have this primitive gut. When you see this gut, it is divided into three. The derivatives, you say the derivatives of the foregut, we have the derivatives of the midgut, we have derivatives of the hindgut. Over here in this diagram, you can appreciate this is the foregut. Over here, we have the midgut, and then we have the hindgut. So from this, the various structures or the organs develops. Now, when we see over here, this is the foregut, the primitive part, the proximal part of the foregut. If you see over here, this area we call it as the pharyngeal gut. Why we say this as the pharyngeal gut? Because the pharynx and the associated structures with the pharynx develops from this part. Now, this caudally, if you can appreciate over here, this is also the part of the foregut only. So this is the stomach. From here, the stomach will develop. Now, the area, the junction between this pharyngeal gut and the stomach, over here, if you see at this junction, there will be the development of the respiratory diverticulum. From this respiratory diverticulum, if you can appreciate, there will be the different structures which will be developing, like we have the larynx, we have the trachea, we have the bronchi, the lungs, parenchyma, etc. Right? Now, in this diagram, if you can appreciate, at the 4th week of development, from the ventral aspect of the proximal part of the pharynx, you say, or the proximal part of the foregut, or you say the proximal part of the pharyngeal gut, right? Over here, you can appreciate there will be a development of the median endodermal diverticulum grows into the adjacent splanchno-pleuric mesoderm, you say, which is otherwise, just now I said, it is the respiratory diverticulum. Now, this diverticulum is first seen as a midline groove. We call it as the laryngotracheal groove over here in this diagram, you can appreciate, which is present in the floor of the primitive pharynx. Now, when you see this diagram over here, this is the diagram showing the different pharyngeal arches, the first, second, third, fourth, and the 6th pharyngeal arches. Now, everyone knows that the 5th pharyngeal arch degenerates. So over here, you can appreciate the 4th and the 6th pharyngeal arch. Now, over here, associated with the 4th pharyngeal arch over here, you can appreciate this hypobronchial eminence. Now, if you can see over here, this area we call it as the floor of the pharyngeal gut. What happens that there will be the increased secretion of this retinoic acid, which will upregulate the transcription factor TBX4. And because of the increase in the transcription factor TBX4, there will be the appearance of this laryngotracheal groove. Now, this groove, the laryngotracheal groove, if you can appreciate over here, it deepens. As a result of the what will happen, the diverticulum becomes more pronounced. What we discussed initially, this respiratory diverticulum, or it is called as the laryngotracheal diverticulum. So because of this, the groove, what will happen? It will deepening of this groove, diverticulum will become more pronounced longitudinally, and this will be called as the laryngotracheal diverticulum. Now, what will happen? That the primitive foregut, distal to the pharynx and proximal to the stomach, as we have seen in the previous diagram, remains tubular and elongates. It elongates to form the esophagus. Now, what will happen? That initially, when you see this esophagus, it will be short, but there are a few factors because of that. This esophagus will elongate. What will happen? First, because of the development of the neck or the elongation of the neck. The second is because of the descent of the diaphragm. And the third one, because of the descent of the lung and the heart, you say. Because of those factors, what will happen? That the esophagus will elongate. Now, what will happen? That the groove deepens and its lips fuses. You can see over here in this diagram, the groove will further deepens and its lips will fuse from its caudal end to form a septum, which converts the groove into a tube. And that we'll call it as the laryngotracheal tube. Over here, you can appreciate this is the laryngotracheal tube, which was initially a diverticulum, has been converted into a tube. Now, the tissue between this separating laryngotracheal tube and the primitive esophagus, this is the laryngotracheal tube, and the primitive esophagus, you can appreciate over here, is known as the tracheoesophageal septum. So when these lips will fuse, there will be the formation of the septum. We call it as the tracheoesophageal septum, which is the connective tissue. Now what will happen? The tube will remain open at its cephalic end, where it connects to the pharynx. So cranially, it will be connected to the pharynx. Now what will happen? There will be two lateral outgrowths. You can see in this diagram over here, there is two lateral outgrowths arise from its caudal end to form the stem bronchi and the right and left lung buds. You can appreciate in this diagram. So what will happen as this laryngotracheal groove deepens externally, right? It leads to the formation of the tracheoesophageal folds, right? Over here, you can appreciate in this diagram also, the groove will deepen, which appears at the fourth week. It will deepens down and there will be formation of the tracheoesophageal folds medially. Now what will happen? That this tracheoesophageal folds fuse with each other in the midline, and it will form the tracheoesophageal septum, which will be separated out, and it will form a anteriorly we have the trachea, and posteriorly we'll have the esophagus. Now in this diagram, if you can appreciate over here, what will happen that its cranial part communicates with the pharynx and it forms the laryngeal inlet, right? Now the cranial part of this diverticulum forms the laryngotracheal tube, which in future forms the larynx superiorly, the cranially, and inferiorly we have the trachea. While the caudal part, if you see, it grows distally, enters the thorax, and it becomes bifid. You can appreciate over here, it becomes bifid, which will be called as the lung bud, which in turn forms the bronchi and the lung parenchyma. Now, when you see over here in the next diagram, what will happen that, as I said, there is a formation of the tracheoesophageal septum. During this time, what happened that ventrally developing laryngeal tracheal tube, you can appreciate over here, the ventrally developing this laryngotracheal tube, or in the cross section, you can appreciate this is the primordium of the laryngotracheal tube. Now, what will happen will be separated from the future esophagus by a wedge of mesoderm. That's what we call it as the tracheoesophageal septum. Now what will happen? There will be proper formation of this septum, which will be critical in separating the future trachea. You can appreciate over here, right? The folds will fuse and there will be formation of this tracheoesophageal septum, and these will separate out, and what will happen as a result of that, there will be formation of the trachea and esophagus into the normal anatomical structures. Now, what will happen that when you see over here, the septum is coronally oriented, right, and caudally placed. And what will happen? The growth will happen rostrally. You can see towards the front. The growth will happen rostrally. Now, what will happen? When you see this formation of the tracheoesophageal septum, it usually completes by the 6th or the 7th week of development. Now, when you see this trachea, the endodermal lining of the middle segment of the laryngotracheal tube, which forms the epithelium and the glands of the trachea. Now, what will happen? That the mesenchymal cells surround the tracheal tube, and ultimately it will form the cartilage, connective tissue, and smooth muscles of its walls, you can say. By, you say, the 8th week, the size of the embryo, which is approximately between 28 to 30 millimeter, what will happen? That the mesenchymal rudiments of the 16 to 20 tracheal cartilages are seen in the next, or you say the following 2 weeks. What will happen? The masses from the cartilages beginning cranially and extending caudally. What will happen as a result of that? The cilia will appear at, you say, around 10 weeks, and at that time the size of the embryo will be approximately, you say, the 51 to 53 millimeter of you say the size of the embryo. And by 12 week, you say, the mucosal glands are seen and develop in the craniocaudal directions. Now, by the end of the 20th week, say, the all major microscopic features of the trachea you will be able to see. Now, what will happen next when you see over here in this diagram? Now, dorsal aspect of the foregut you can appreciate over here. This is the dorsal aspect of the foregut, which you can appreciate over here is the esophagus. In this diagram, you can say this is the dorsal aspect of the esophagus. Over here, we have the trachea, and cranially, when you can see towards the ventral aspect, you will have the larynx, whereas towards the dorsal aspect, you will have the pharynx. Now, in this diagram, whatever we have discussed, we'll just try to summarize. So this is a video showing this development. You can appreciate over here. This is the formation of the laryngeal opening, you can say, that is at the week of the 4th week of the old embryo. Over here, you can see the foramen cecum, hypopharyngeal eminence, and the 4th pharyngeal arch, and the appearance of the laryngotracheal groove in the floor of the pharyngeal gut, you can say. Now, when you see over here at the 5th week of the old embryo, you can appreciate the this hypopharyngeal eminence over here, and there will be the formation of the laryngeal inlet you can appreciate over here. This is the laryngeal inlet. Superiorly, you can see over here, this is the epiglottis, and towards the lateral aspect, if you can appreciate, these are the arytenoid swellings, right? So this, if you see, it is a T-shaped structure you will be able to see at the 10-week embryo, and you can see the arytenoid swellings over here, right? Now, when we see the trachea, the bronchi and the lungs in this video, you can appreciate over here. I said at the junction of the pharyngeal gut and the stomach, there will be the development of the respiratory diverticulum. You can appreciate in this diagram. Then what will happen at this section, you say, this is the ventral aspect and this is the dorsal aspect, where you can find this pharynx, and caudally you will be seeing this esophagus will develop, right? So this is the respiratory diverticulum. Now there is a formation of the groove over here. The folds will fuse and there will be the formation of the septum. Now this septum, which is called as the will be separated out, and it will form anteriorly the trachea, that is the laryngotracheal tube. Superiorly, caudally, we have the larynx, laryngeal inlet, and inferiorly, we will have the trachea, and posteriorly, cranially, we'll have the pharynx, and caudally, we'll have the esophagus. So over here in this diagram, you can appreciate that this is the trachea, and then you will have the lung buds over here. Now, this is the diagram showing the tracheoesophageal fistula. So if you see over here, what I wanted to say, that the trachea and the esophagus develops from a common primitive gut. So over here in this diagram, you can appreciate this is the trachea dividing into the two principal bronchi, and this is the normal esophagus. Cranially, we'll have the pharynx, and then we have the esophagus. And caudally, you can see it will continue as the stomach. So develops from a common primitive foregut, you say, and at approximately 4 weeks of gestation, I said the developing respiratory and the gastrointestinal GIT tracts, you say, GI tracts are separated by the epithelial ridges. Now what will happen? The foregut will divide into a ventral respiratory tract and a dorsal esophageal tract. Now what will happen? By the tracheoesophageal septum, I said. Now, any defects of mesenchymal proliferation or you say the tracheoesophageal septum will lead to the abnormal communication between the trachea and esophagus, and that will lead to the tracheoesophageal fistula formation, right? When we see at the molecular level, what will happen, there is a gene, we call it as the SHH, that is called as the sonic hedgehog, which is implicated in the, you say the vertebrate axial organogenesis, the formation of the organ. Now, that appears essential to the foregut development and its differentiation. Now, what will happen, that there will be the reversal in the dorsoventral pattern of the SHH expression during the tracheoesophageal separation stage. And in the andriamycin model, you can say, that is in mice with targeted SHH deletion, there will be the development of the, either you say esophageal atresia or the tracheoesophageal fistula will develop. Now, defects in the SHH signaling pathway that will be linked to the mutations in the GLY2, GLY3 gene transcription factors will be there, and that will result in the Bacterial complex or the phenotype what we discussed earlier. Now, we'll show you the different types of the tracheoesophageal fistula. As I said, that this tracheoesophageal fistula will usually occurs with a related condition called as the esophageal atresia. So over here in this diagram, you can say this is the normal trachea and this is the normal esophagus over here, the stomach. This, if you can appreciate over here, this is the normal trachea, but over here, what will happen, that initially this esophagus, as I said, it is a tubular structure. Initially, it will be solid, but there will be the endodermal cells, right? And because of that, the recanalization will be there. Whenever there is a failure in the recanalization, it will lead to the, you say, the atresia, that is the esophageal atresia. When there is a failure in the recanalization, it will lead to the esophageal atresia. When there is an improper recanalization, that will lead to the stenosis, right? That is the narrowing of the esophagus. That is called as the esophageal stenosis. Now, in this condition, if you see over here, right, what happens, that the trachea is there, but there is a communication between the trachea and the esophagus. So this we call as the tracheoesophageal fistula. The one end is opening into the trachea, whereas another end is opening into the esophagus. Or what will, as a result of this, what will happen, that whatever the food materials will be taken by the newborn, right? The first feed will be okay, but from the second feed, what will happen, that it will may enter into the trachea, and because of that only the respiratory distress or choking will be there, right? Or apart from that, what will happen, that whatever the trachea, the wind will be there passing through this trachea, it may enter, it goes into the esophagus. So when you see this X-ray, right, you will be able to appreciate the gas in the stomach, because every time the infant will inhale, some amount of the air, the wind will accumulate into the stomach. Now, that the clinical picture will be better discussed, by Professor Satyashri ma'am. Now, if you see over here, this is the condition we call as the tracheoesophageal fistula with esophageal atresia. So over here, you can see there is a communication between this trachea and the esophagus. Apart from that, over here, you can appreciate esophageal atresia as well. Now, when there is a communication prior to this, we call it as the proximal tracheoesophageal atresia with what I said, the proximal tracheoesophageal fistula with esophageal atresia. Now, in this condition, if you see over here, the fistula is towards the distal end. So in spite of the proximal, we will say distal tracheoesophageal fistula with esophageal atresia, right? Now, in this condition, if you can see, there are double communication, proximal as well as in the distal, and the esophageal atresia is there. So double tracheoesophageal fistula with esophageal atresia. And in this condition, if you can see, this is the esophageal stenosis because there is a narrowing of the esophagus. So that I said because of the incomplete or the improper recanalization of the esophagus. Now, when we say it has been, if you see over here, there are the different kinds. The most common you will find is this one, right? So over here, esophageal atresia is there, right? And what will happen? This is the, either you say this or this, the 90% cases, you will find this kind of the atresia. Now, apart from that, if you see this kind of, you will find this esophageal atresia you can make out over here. It will be approximately, that is the isolated esophageal atresia in 4% of cases you will find. Whereas the H type, if you see over here, right, this in this, that you will be getting approximately 4%. Whereas rest, this kinds, if you say, you will be getting in 1% of the cases. Now, just to summarize, if you see over here, this is the another video. I'll try to show
from the mouth and nose to the lungs. The trachea forms during the 6th week of pregnancy. Here, you can see the tube that will eventually form all the organs of the digestive system. The trachea and lungs grow from the part of the digestive tube that will eventually become the esophagus. For unknown reasons, the esophagus and trachea may grow and separate abnormally during this time. The esophagus may end in a blind pouch with missing gaps and be abnormally narrow. This absence or narrowing of a natural body passageway is called atresia. The esophagus and trachea may also have an abnormal connection called a tracheoesophageal fistula. Here we see the most common type of tracheoesophageal fistula in a newborn infant. The upper esophagus ends in a blind pouch, and the lower esophagus connects to the trachea. This is a serious problem because stomach contents can travel up the esophagus and pass through the fistula into the trachea and lungs. The fistula can also cause difficulty breathing for the newborn, since air can now bypass the lungs and enter from the mouth and nose.
So at the end, I would like to add over here that the hereditary and the environmental factors which affect the embryo before 23 days, you say, would produce severe lesions, such as you can say the complete absence of the trachea or the esophagus, whereas later in the 4th week, or you say the as sensitivity regresses and the respiratory system has developed further, you will find the minimal defects, or you say the minimal defects can be expected, such as the typical esophageal atresia, you can say, with distal tracheoesophageal fistula. And after 32 days, this type of foregut malformation will not be expected at all. So this is all about this anatomical basis of the tracheoesophageal fistula. So thank you so much. And I'll end my talk. That is, an anomaly is not an abnormality. Diversity does not signify the sickness. So this tracheoesophageal fistula, the beauty of it is that it can be treated surgically. Thank you so much.